Today, again, just for recording's sake, we are discussing prescription drug plans in 2025. Not a new topic, but very important, talking about, is Part D worth it? At the end of the day, all these changes stemming from the Inflation Reduction Act affecting drug plans, what's going on? So first of all, products have changed this year dramatically. Will, you want to hit on that?
Absolutely. So we're seeing a lot of changes going on, and this should be no new news to a lot of you. But what we're seeing is, larger than what has been the average med sup rate increases, what we're used to over the last couple of years anyways. And what that is stemming from is kind of a delay in a lot of the COVID care and the COVID claims. A couple of years there, people maybe not going to the doctors, not getting their regular checkups, things of that nature have kind of caused a backlog now as people are starting to go back to the doctor and all of that stuff. And then as well, if we take that to the flip side and look at the Medicare Advantage side of the market, we've got a lot of changes, not only in their cost burden when it comes to some of these Inflation Reduction Act changes that we'll talk about, but as well, a lot of budget constraints for them. They're relooking at how star ratings are handled and reviewed for a lot of the carriers, lower than expected increases on their actual budgets on the plans too. So there's a really big constraint going on in the market that's causing a lot of changes for 25.
Exactly. That's why we're seeing a shopping rate of 80 up to 80% this year because of all these massive changes, and no product is left unscathed. We did some really interesting data research. Def Research has been doing a lot of conversations talking about consumers' loyalness to plans, to carriers, and what does that look like. Something that's really interesting is if your clients are alluded to or understand the changes due to the IRA, they are much more likely to accept those changes and not switch plans because they understand it more. So education is the name of the game this year, but in order for you to educate your clients, we need to make sure that you fully understand what's going on. So number one, prescription drug plans in 2025, many plans, guys, this year are not going to be commissionable. We're hearing from several carriers right out the gate that not only are the product offerings going to be fewer, carriers that offered 4 products in a state are now offering 1, and in many cases that one plan is non-commissionable. Now in a lot of these plans, the renewals will maintain to be paid out. As long as somebody stays in that plan, you'll receive renewals. But there is a massive plan this year that is saying that they are not going to pay on renewals. So anybody on that book of business, if you don't move them to a new plan this year, you're going to cease receiving renewals on that book of business.
And something to keep in mind too, as we're seeing carriers kind of trimming down their plan offerings, is that means that your clients are going to get mapped to that plan that is left in the market. If a carrier went from 4 plans down to 2, there's going to be some plan consolidation there with your clients, which means they're going to get moved plans. They may see premium changes, premium hikes in some instances as we're seeing consolidation. So it's really important to be on top of where those mappings are going and what's happening, and we can help you guys out with that. We can make sure you're on the forefront of what plans are going where and who's getting mapped to what this year.
Great question. With premium hikes, I do have some questions here, Milton. I will answer you. Just let's kind of get through this. I think it's a really important question. We're going to get to it. Another thing we're expecting to see this year are massive premium hikes. Now, there are some things to help kind of slow those down, including that Part D demonstration we talked about earlier. But when they had to turn in their plans, and CMS was looking at for rebids, they were talking about a national average of a premium being up to $135 this year. That's almost 3 times the amount it is in 2024. Medicare Advantage, or excuse me, CMS freaked out and started offering that Part D demonstration. We'll get into that in a little bit. However, a lot of plans that you see were offering $0 premium, 50 cents, $12. Those are a thing of the past. You're going to start seeing those plans offering at least a $35 premium, much likely to be much higher than that. The next thing is going to be talking about formulary changes. We do know that there are some protected drug classes, and they're make sure that every plan does have to have at least 2 prescriptions from every type of diagnostic related group on their formularies. But for a lot of individuals who are taking multiple medications for the same condition are going to struggle to find carriers that take all of their medications. Not only that, but what we're already seeing is bringing back cost share of co-insurance versus copay on tier 3 medications. 4 and 5 kind of already have them, but tier 3, we're seeing resurgence of that and introducing the deductible back on tiers 1 and 2, which is something that a lot of our plans did not see and haven't seen in the last 5 years.
And not only seeing the deductible on drug plans change, but seeing on MA plans change as well. There were a lot this year that did not have a drug deductible at all on those Medicare Advantage plans. We're seeing that kind of come back around for 2025, and MA plans are starting to add on drug deductibles, usually on tiers 3, 4, and 5, but that is a notable change that some clients may see as well.
Yeah. Very true. I'm getting some great questions asking if we can share a list of non-commissionable plans. The ones that we know of so far are Aetna and WellCare. United Healthcare have said that they're going to continue to pay commissions on their Part D plans. Other carriers haven't said yet. Now, typically October 1st, we will get a list of all carriers that are considered non-commissionable. We're hoping to see that again October 1st. We're hoping to see that again this year. The problem is that in the past, CMS has required carriers to publish if they're commissionable or not. This year, CMS isn't requiring that. So we're hoping we will make sure, at least by October 1st, that we're going to do the digging, do the research, and provide that plan for you. Right now, we just know WellCare and Aetna are non-commissionable for 2025 AEP.
I will say Cigna did say that they will be paying on PDPs as well. So that is 2 carriers now that we have yeses from. So Cigna and United Healthcare are standing on that.
Let's see. Aaron asked, when will the landscapes be out? Usually a few days before October 1st. Starting, into September, we are checking almost hourly to see when those landscapes are available. But we do know carriers like Essence, Devoted, United Healthcare, and Cigna have all come out saying this is what, they've sent out the sneak peeks to give everybody a really good feel about what their plans look like. Still waiting on Humana. Humana says early September is when we're going to start to see those. So moving on with this, because again, I do want to be conscious of everybody's time. The value of offering a PDP will shift. I know Michael put it up there, making a commission is not a reason to change a client's prescription drug plans. And Michael, I couldn't agree more. The value of PDP is people are tending to look at them. What is the time spent on helping somebody with their drug plan versus the financial gain from that? And understanding that when we're looking at a high service, high utilization product like prescription drug plans, the financial gain isn't necessarily the total gain. The finances, if you get it, are definitely a perk, but the reason of showing, of presenting and helping people with their prescription drug plan is more for the long-term relationship with that client versus that short-term profit. We're going to talk about that a little bit more in depth here in a minute. Perfect. Okay. Let's get into what everybody is talking about, and I think what is responsible for the majority of the chaos coming into this AEP, that is going to be the Inflation Reduction Act, which is a new rule, a new regulation that helps people. Basically, who does the Inflation Reduction Act? Up until this point, it's helped everybody. We can thank the Inflation Reduction Act for things like price negotiations, $35 insulins, vaccines now being covered, vaccines that were not covered before and now being covered by Medicare Part D. So there's a lot of good things, a lot of positive things that have come from the Inflation Reduction Act. What we're seeing in 2025 are 2 significant things. Now on paper, these things are really impressive, especially for those 10% of individuals that enter catastrophic coverage. People who are spending extraordinary amounts of money on their medications are now going to see a $2,000 maximum out of pocket, which is significant. I mean, it's $8,000 this year, cutting that down, by 4 for next year. For those individuals who are really struggling and hitting that catastrophic coverage, this is life-changing updates. This is very significant for them. The problem, and there's a lot of problems, but again, we talked to Deaf Research yesterday, the majority of individuals when surveyed, of beneficiaries when surveyed, again, the vast majority had no idea that it was coming up for AEP, and the majority of the ones who did know that it was coming up for this AEP thought that the $2,000 maximum out of pocket wouldn't affect them, period, because they spend less than $2,000 on their medications now. they're not understanding the repercussions of what that is doing to their Medicare Advantage and the prescription drug plans. Will, do you mind kind of shedding some light of why this is affecting these drug plans?
Yeah, so the big reason that this is impacting carriers and plans is the cost burden shift. I talked about it a little bit at the start, but I'll kind of give, a frame of reference here, looking at in 2024 plans, what that cost burden is. So obviously we know the coverage gap is going away in 2025. So when someone hits their initial coverage in 2024, the Part D plan was responsible for 75% of the payments after that. In the coverage gap, the PDP plan, the MAPD plan was only responsible for 5%. What we're seeing though is when you shift that to 2025, when someone hits their catastrophic coverage, the Part D plan is responsible for 60% of what is paid after that front. In 2024, that was 20%. So they are 3 timesing the responsibility that they have when a client hits the catastrophic coverage. And like Olivia said, with that catastrophic coverage amount coming down, now having that $2,000 max out of pocket that someone could potentially pay, that is a massive cost burden that we're talking about. If we're going from paying 20% now up to 60% when someone hits that $2,000 number. So that is a big cost burden to take on for the plans. And that's got to go somewhere, right? We know they've got to work with it and they've got to make it fit and make CMS happy with plan filings as well. So that's got to be redistributed somehow onto the plans and back onto the benefits that come out for 25.
Exactly. And again, people not understanding, that's whenever people are going to go from a $0 premium to a $35 premium, right? People are much more willing to accept that premium increase if they understand why. So that's why Integrity has built this incredible IRA presentation. It's considered an educational event, which does not need to be registered, but it gives you the capability to educate pharmacists, educate financial planners, and educate consumers about what is going on. Because again, the mass majority of people have no idea that this is coming and have no idea how it's going to affect them. So that is huge. Now I'm still seeing a lot of questions coming out here asking about particular carriers and their paying commissions on Part D. Because this is a nationwide webinar and because we have all sorts of levels of people on here, we can't get into specifics about this, but call our office. We will give you everything that we know. We just can't do it on a mass basis like this. But again, we did mention that WellCare and Aetna are non-commissionable plans this year. I can't say too much on a wide webinar like this one, but one of those plans is also saying, it might rhyme with Melcare, is also stating that they're going to be their renewals. They will not be paying renewals. That can change. There is still time for them to change that. That's not set in stone, but that's just what they're talking about right now. So call our office. We'll give you the 411.
Absolutely. And Olivia, to your point on that IRA presentation that Integrity put together for brokers to use, that's a great tool to network with pharmacists. If you don't have a pharmacy relationship existing or you want to add more into your referral repertoire for this AEP, that is a wonderful tool. As we'll talk about here in a second, the smoothing provision, it's going to have a big change for pharmacies as well. A lot of pharmacists and pharmacies may not be as knowledgeable as they need to be to serve beneficiaries if they come in and have questions on what is this smoothing provision I'm being told by my insurance agent and my carrier that I'm eligible for on this super expensive medication. That makes you come in and look like the expert that you are and helps you develop some great referral partners this year.
Yeah, I'm getting a lot more questions. We are going to address them. How do we handle not getting paid for Part D? Can we tell our clients about this? Do you recommend sending them to Medicare.gov? We're going to get into that. We have some really good insight and studies that show what is the right option, both financially and as well as the relationship with the client. So the second part of the Inflation Reduction Act, obviously the $2,000 MOOP, it's really easy to take a pencil, draw it from that all the way to higher premiums, hurt formularies, weird benefits, everything in between. What I've been referring to as the little sister that doesn't get to go to prom is the smoothing provision, and also called the M3P. Yes, M3P. I get it confused with MP3.
I want to say MP3 every time.
And I'm like, that's not right. That's not right. This is amusing. Which is the okay. So I'm gonna butcher it. It's the Medicare prescription program something.
Premium stabilization demonstration.
No, just talking about
Oh,
what's the other word for
yeah,
the
yeah, the
smoothing provision.
M3P, yes.
Yes. Okay. So the Medicare prescription payment plan, if I just would have moved to the next slide, I would have looked less dumb. This is one, again, that is causing a ton of questions and is offering it on paper, again, really positive things. For those individuals, okay, so long story short, what the M3P is the ability to finance, get 0% interest financing from the carrier to pay for your medication throughout the rest of that plan year. So if I go to the pharmacy and I'm taking a medication that's got a co-insurance and it's going to cost me $2,000, then instead of saying, hey, do I pay for food and my rent this month, or do I pay for this medicine? I can go ahead, take that medication, start getting better, start taking care of myself, and have that financial burden spread across through the next 12 months. Now, because of this, what this looks like is, unfortunately, this puts a ton of administrative burden on both the carriers and those pharmacists, because the carriers are the ones who are responsible for putting up the financing and for administrating those collections. Now, unfortunately, if the beneficiary fails to pay back that money over a 12-month period, or whatever the remainder of that benefit is, the carrier cannot terminate that consumer. They can only take them off that smoothing provision. So the carriers are now having to come up with the potential and the likelihood that they're going to incur some negative debt, some non-investment of debt. And so this is obviously not only the administration cost, but also the likelihood of them losing out on a significant amount of money. Now, we also know that this will also affect pharmacies, especially those mom and pop pharmacies that maybe don't have the overhead to afford that. So, Will, do you mind kind of talking about this from the pharmacy's point of view, as well as their ability to opt out?
Yep. So on the pharmacy point of view, when you're looking at your mom and pop pharmacies, your local pharmacies that we all know and love, you're coming in, you've got a client that has a $1,500 medication. You're expecting to get that $1,500 in that moment. You're expecting to see that payment. You can put that towards your overhead for the month. But if someone has opted into the M3P, it's going to look a lot different. Yeah, I know it. So if someone's opted into the smoothing provision program, that's going to look a lot different for that pharmacy. They're going to have to wait a little bit of time, and they're going to be paid actually by the carrier afterwards. So that client is going to pretty much walk in. They're going to have that payment plan set up. Say you've got a $1,500 medication and you're picking it up in February. So you've got 10 months left to pay that. Client's going to pay $150 a month pretty much to the carrier, and the carrier is going to then have to pay the pharmacy directly. So that pharmacy might be waiting 30 days to get that payment. That is a huge burden when you think about the amount of clients that could potentially opt into this, or could potentially opt into it for multiple medications as well. So that's a big shift that the pharmacies are going to have to deal with from a financial standpoint, which is going to be hard on your mom and pop pharmacies, which, as we all know, are already struggling. So that's why, when I was talking earlier about developing those referral relationships, that's going to be huge. They need to be educated about this, and they need to be informed on what this looks like. And oh, sorry, need a drink of water real quick.
You're good. But no, I, again, completely understand. Talking about prescription drug plans and having the ability to represent them, having the ability to enroll them, not only will, again, we'll talk about is it worth it or not, but the opportunity, the networking opportunity to work with pharmacists. We were working with an agency that we actually gave them, we have this for all of our agents, but they went to 3 pharmacists and gave them the, hey, this is what the smoothing provision, here's a one-sheeter that goes over smoothing, that goes over the $2,000 MOOP, and they got 7 appointments out of that week from seeing 3 different pharmacists. And that was because the pharmacies have no idea what's going on too. When CMS was asked, hey, who's talking about this? Who's talking about the IRA? Who's talking about the smoothing provision? Who's educating these people on it? CMS said there are 3 parties responsible: carriers, pharmacists, and agents, or carriers, providers, which would include pharmacists and doctors, and insurance agents. So saying, so I agree. I know Kay said the carriers need to step up their correspondence. 100% I agree, but it's also CMS is also putting that responsibility on pharmacies and on us as agents. So making sure that earlier, I heard a really interesting quote yesterday talking about defense versus offense. It's going to be a huge year for defense versus offense this AEP. Defense, in order to keep our book of business, that happens now. That your defense is happening all the way up until October 1st. By teaching people about this, by building those relationships, by educating your clients, and then that means October 1st, you can go on the offense and gain a lot of business this year, gain a ton of people by talking about this information, because a lot of agents will probably be waking up October 1st, not really sure what's going on. So huge opportunity. Being able to represent Part D is a significant chunk of that.
Yeah, and I see a lot of great questions about resources and documents. They kind of outline a lot of this stuff. We have a ton of great information on our AEP toolkit on the SMS team website. We actually have an entire IRA section in the AEP toolkit that has a lot of really good one-sheeters, both for clients and something that you can take to your pharmacies as well. So if you guys haven't checked out the AEP toolkit, please call our office and we can walk you through it and we can get you over these one-sheeters as well.
Now, Linda asked a great question. Can a pharmacy opt out of the M3P? In short, no. It's all or nothing. If a carrier or if a pharmacy wants to continue to accept Medicare prescription drug plans, they have to be able to offer the MP3 program. They cannot opt out. In fact, if a medication is over $600, the pharmacy is required to educate their client about the M3P program. So no, carriers cannot opt out. Pharmacies cannot opt out either. I'm seeing another question. How does one person apply for the M3P, or when can they opt into that program? It's likely there's going to be multiple methods of opting in, one of which is likely to be at the time of application. You will also be able to call the carrier after the fact, and you should have the ability to opt in at the pharmacy as well. So it'll be very available to opt in anytime. Even if you don't opt in at the time of applying for it, you can opt in halfway through the year if you want to. There is no timeline of when you have to opt in to participate in that smoothing provision. Sorry, I'm just looking at this. Yes, Brian, you can get that one-sheeter. It's in our AEP toolkit, like Will said. Call our team. There's so much stuff on there. We've spent a ton, us and our marketing team has spent a ton of time helping agents prepare for the IRA. And like I said, the depth research is showing that the earlier your clients are educated about what's going on, the more likely they are to remain on the plan, because they will understand the rate, they will understand those increases and benefit drops. The earlier they educate, the better you're going to be. Let's see, Lee is asking if we can cover the IRA. That's what this is. Both the $2,000 maximum out of pocket put on prescription drug plans and the smoothing provision is what's going to happen in the IRA for 2025. Now, the IRA and what everything goes on is actually a program that goes all the way and implements change all the way through 2035. It was something that was introduced during the Biden administration. So if there is a change in administration, we may see some changes to that provision in the future, but the way that is written up today goes through 2035. And I'm seeing a lot of questions. I want to make sure, again, I do want to make sure that I am conscious of everybody's time. So I am going to move on and save some of these questions to the end, just to make sure we get through everybody. Let me see. There's one. Perfect. Did I miss anything as far as the smoothing provision, Will?
Nope, I think we've covered everything that we can on that one.
Perfect. Ooh, I do want to answer this question really quick, Patty, because it does have to go with the IRA. She says, can we start educating our clients now instead of October 1st? Yes, that is a question that we get a ton on, because as we know, we cannot discuss 2025 benefits until after October 1st. However, we're not talking about carrier specific. We're not talking about plan specific. We're talking about what the coverage is and the makeup, the new way that a prescription drug plans are going to be shaped and looked at. This information has been published since 2022. So your clients, you are absolutely able to educate your clients today about the IRA. The only thing I would hesitate to educate on is going into talking about Part D premium and an extent going into talking about Medicare Advantage benefits, because then you're kind of getting into some more of that specific carrier stuff. However, if you stick to, again, we have a PowerPoint on our website that goes into the IRA and goes into what is a compliant presentation. It would be considered an educational event. Stick to that. You're good. That has been cleared by Integrity Legal to make sure it is compliant. You're going to be okay. Oh, Joseph, you're asking a great question. I want to get to it at the end because it doesn't affect them as much, but major changes are coming to DSNP.
Absolutely.
Let's talk about what is coming to, I'm going to say, quote unquote, save these prescription drug plans. And that is going to be the premium stabilization demonstration. Essentially, I kind of already hit on it, but what had happened was that when carriers started presenting to CMS and sitting and submitting their bid saying, this is what our Part D plan is going to look like this year, the average premium was $135. Which is nuts, which is insane, which is considering in 2024, the average was about $55. So CMS kind of panicked last minute and said, we're going to go ahead and give prescription drug plans an opportunity to receive subsidy. They're going to get money from the government. Basically say, if you promise not to hike these premiums up the way that you're submitting, you're going to get some extra dollars from CMS, essentially from the US taxpayers. So this means CMS, if a plan opts into the premium stabilization demonstration, and they had until it was August 7th, I believe, so they had to have submitted that a long time ago. But if they would have said yes and opted into it, then essentially the plan itself would get a $15 subsidy for that base beneficiary premium. And in return, the carriers are not allowed to raise their premium by more than $35. Hence why you're seeing whenever these plans are coming out with their sneak peeks, you're seeing, oh, this looks like it was just $35 more than last year. Yes, exactly. So these $0 plans, and this is just for the PDP side of things, just the drug side of things. So when you're seeing $0 drug plans or 50-cent drug plans, it's probably going to be $35.50 this year.
Mhm.
So going into that, essentially what that means is that CMS is willing to work with these plans, try to get involved with them. The plans still do, that does put more financial burden on these prescription drug plans. However, there is a ton of incentive for prescription drug plans and carriers to opt into this program, because if they don't do it this year, they're locked out for the next 3 years. So
Yep.
not only it's like honestly, the high pressure, high sale situation. We have a huge deal for you, but you have 7 days to give us an answer. That's essentially what happened here. We don't know for sure. Carriers are not coming out and said, yes, we opted into it, but the carriers that are publishing their Part D numbers are seeing a $35 premium increase. So it's safe to say most carriers took them up on that offer.
Yep.
Okay, I'm looking at some more questions. Can you please post web address and contact numbers? Yes, Ken, we will get your information. It's at the last portion of this slide. We'll make sure you have a way to contact us for sure. And again, I want to make sure that I can answer your questions, but they're coming in really fast, and so I might have to wait to the end to answer most of these. Anna said, can we tell clients that the plans can only go up by $35? Anna, I don't know, because you're talking specific premium, specific things. I would say no, but I don't know that for sure. Our compliance officer is today, they're speaking at a conference in Kansas City. I would ask him his 2 cents on it. That's a really great question, Anna. I have a feeling that it's no, but I'm not confident enough in that answer to say that, because it's not a part of the IRA. That's completely something separate. So I don't think that's beneficiary knowledge. And so that's a great question. We'll find that out. Let's see.
Aaron asked a great question a little bit ago. Yes, $600 or more, the pharmacy is required to educate the client that the M3P is an option for them.
Ray said, would it be easier to just include a link on this response of these resources than it would be to have 100 agents calling our office? If 100 agents call our office, that's a good day for us. We want that. Yes, please call our office. We want to talk to you. We want to help you. But the
I want
other
all the phone calls.
Exactly. We want that, but I understand that may not be the most convenient for you. Ray, these tools and materials that we're talking about, including the webinar, or excuse me, including the PowerPoints, these forms, we require agents have at least one contract with us. This is a partnership. If we want to help you, we want to make sure that you're helping us in return. So in order to gain access to our website, you do have to have at least one active contract with us, preferably more, but one gets you the ticket. So that's why I can post it to you, but you may not have access to it, just to be fair. Okay, so that is the,
Yes,
go ahead.
this webinar will be available later as we are recording it.
So any more questions? What we're getting to next is actually our last point, and that's talking about, is prescription drug plans worth it, which is kind of an overwhelming majority of these questions. So before I get into that, I just want to wrap this up with a pretty bow. What's going on with prescription drug plans this year? Again, just pretty bow before we get on, is it worth it or not? Up to an 80% shopping rate of Medicare Advantage beneficiaries. 90% of Medicare beneficiaries are expecting to see negative impacts on their ANOC. They will see a decrease in benefits or an increase in premium going to their Medicare Advantage or prescription drug plans this year. Massive, massive disruption. It is your opportunity to educate now. Educating is proving to teach people, or is proving to show that people are much more likely to understand and accept this change versus doing a ton of shopping without your knowledge. It is going to be incredibly important that you have tools, systems, and resources to make the most out of your AEP. Because though we all are going to be, keyboard warriors, and we're all going to be like, I'm going to work 90 hours a week during AEP. If you try to do that, you'll get sick. You'll be out of office. It'll end up worse for you. You only have so many hours in the day. Let us help you make the most out of it. Early education is the #1 way to combat that. Let's talk a little bit. I said ask me your questions, and I want to make sure. Who do I recommend for Part D plans as AEP? Michael, what a loaded question. Let's get into this. Let's get into that a little bit, because what we're seeing is that most prescription drug companies and plans, most prescription drug carriers are limiting their plans to one. I know I mentioned that earlier, but they're limiting their plans to one. So to say I recommend this carrier for AEP is not an option. Just like it is on the Medicare Advantage side, you are going to have a deep shelf of product and represent multiple types of carriers this year, because the variances that we're seeing between plans is going to be more than we've seen. Honestly, I've been doing, this will be my 12th AEP. This is the most variance in plans I've seen year to date. So it's going to be wild. Now, I do want to answer one more question. Was the question of like, hey, with all these changes with Part D premiums, all these changes with MedSup premiums, are people going to do a mass exit into Medicare Advantage plans? Great question. On average, everybody talks about it. Everybody says that they're seeing it. On every single year for the last 2 years, we're seeing a 3% migration of Medicare supplement clients moving to Medicare Advantage. So 3%, not a ton whatsoever. People are still purchasing Medicare supplement plans. In fact, Def Research when their studies said that even if consumers, even a Medicare supplement consumer saw a $50 increase in their Medicare supplement premium, 7 out of 10 of those beneficiaries said that they were not interested in moving to a Medicare Advantage plan. And that's with a $50 increase on that Medicare supplement. Only 30% of individuals said that they were interested in moving into a Medicare Advantage plan. So even though these premiums are significant, we will likely continue to see some migration, but certainly not the overwhelming amount that maybe a lot of us were afraid of. Okay.
And within that DEFS data as well, they talked about what the dollar point is for a MedSup client to even consider shopping and consider switching. And it didn't take, so for the MedSups to hit a 50% consider shopping rate, it was a $20 a month premium increase for them to even consider shopping their plan. And that means even shopping MedSup to MedSup. So MedSup clients are very loyal to their MedSups. It takes a pretty strong increase for them to even consider moving that MedSup.
Do you know what's really interesting though, Will? Whenever that same research done, I was looking at my phone, I think, that same research showed that on a Medicare Advantage plan, people are more loyal to the premium of a Medicare Advantage than they are the actual Medicare Advantage carrier. So it was showing that, I think if a premium went up,
it was like $5 on MA plan.
If it went up $5, yes. almost 40% of people, if their Medicare Advantage plan went up $5, 40% of individuals said that they would be shopping plans this year.
And I think that goes to kind of what we're going to talk about in this last slide of setting those expectations, right? Your clients over the last 4 or 5 years have kind of had expectations that my MA plan is $0. I don't pay for this coverage.
Oh,
So
no.
when we talk about getting, 90% of people expected to see a negative ANOC, that's a huge chance for you as their agent to set the expectation up front as to why this is happening and why that's causing. So it's a great chance to educate, set expectations for your clients coming in so that you guys have some time and some room to breathe this AEP.
Okay, I do want to answer all these questions, but for the sake of time, are PDPs worth it? Yes. I know this is a controversial topic, but Medicare prescription drug plans, in my opinion, I'm going to go ahead and pull these up. Prescription drug plans are the #1 way for client referrals, the #1 way for professional referrals. They are the #1 retention tool. It is the one plan that your clients are likely to use every single month. And if you are saying that you don't want to be a part of that process, something that affects their financials more than any other plan that they have, it affects their financials so much more. If you're saying you're not willing to be a part of that process, you are teaching your clients that the value of an agent is not there. If you're not willing to help them with that, then you're teaching them that there is more valuable methods than using an agent when choosing your health coverage. I'll say it like this, I understand, even if these plans are commissionable, even if they are, you're not keeping your lights on with a prescription drug plan commission. You're not.
Yeah.
Prescription drug plans, we treat them as lead programs. We treat them as referral tools. If you get a commission on it, honestly, that's just a cherry on top. Going to an agent and not having them help you with your prescription drug plans would be like going to a dentist and your dentist unwilling to clean your teeth or fill a cavity. You're much more likely to need a teeth cleaning and much more likely to need your cavities filled than you will a bridge or some sort of major, like they're not going to make money off of that stuff. They make money off the bridges. They make money off the roof. What's it called when you take a tooth out and put another one back in?
Root canal?
Sure. They don't, I
I don't
don't
know.
know. I didn't go to dentist school, okay?
Nope.
They don't make money off of that stuff. However, you would not go to a dentist that was unwilling to fill your cavities and unwilling to clean your teeth because
Yeah.
exactly. So making sure, yes, if you're writing prescription drug plans that are non-commissionable, yeah, that hurts to spend time and effort and resources on something you're not getting financially compensated for, but it's long-term profit versus short-term gain. 100% my 2 cents on that.
And I tend to agree. The way I've been telling a lot of agents to think about it and to look at it is to think about the renewal dollar amount on a PDP. And we think about the referral basis as well and the value of getting those referrals from not only your clients for another one, but for professional partners as well. Think about your referral dollar amount for a PDP divided out over the course of a year. That's, essentially your monthly renewal income from that PDP. I would be willing to bet that a lot of you guys and a lot of you agents can find additional value add products such as dental or hip or cancer or life that can help replace that commission income that you're losing in the short term. So it obviously hurts, and seeing the full picture dollar amount hurts. At the end of the day, no disputing that. But I think if we kind of break it down by client, there's a lot of opportunity there to still be the advisor and still be the value add broker that we all know you are.
The biggest thing, well, I'm not gonna be the numbers person. I'm the fields and the marketing person. So it's always gonna really count down, like, what does that mean for you? The one thing I would really encourage everybody to look at, obviously, I will not be in a room where I suggest somebody either not take a prescription drug plan or not sell a prescription drug plan. It's just, there's too much risk involved. I'm not ever going to be that person in the room. I will be the person in the room that says, if you're meeting with your Medicare supplement clients and everybody will need a drug plan review this year, Medicare supplement or Medicare Advantage, everybody, because of everything we talked about, will need a review. That does not mean every person needs an appointment. To be very clear, those are not the same thing. So using technology, again, I'm going to talk to this, and I get it every time I get this, like, oh, my clients will never do that. Okay, hang with me here. Using technology to get the people who are 65 through 72. Like, let's just take that chunk of people. Using technology, you have the ability to send a consumer their own profile. They do not need a username and password to access it, but they'll have the capability of updating their own providers, updating their own pharmacies, and updating their own prescriptions. You don't have to be involved in it at all. Even if they're confused and need help with that, a phone call helping them through that process will still save you hours compared to them bringing in their gallon grocery bag full of their medication bottles, right? So even if you only have 10% of your clients who are willing to use technology, which by the way, I guarantee you it's way more than that. The number one source of e-commerce came from people over the age of 55. And the number one demographic that values convenience is the baby boomer demographic. Thanks to Deloitte research, we know that. So like, don't count this out. I promise you, people are wanting it. Having the ability to have them update their own drug list, update their own information. Now they have also with this technology, it's Medicare Center. They have the technology to shop the plans themselves. You don't have to do that. All you have to do is get them to update their own medications, update their own list, go to Medicare Center, quote them, see the plans side by side based on the information they entered in, text them, say this is the plan that you need, or email them. They push a couple buttons, they're enrolled in that plan. You can eliminate the appointment altogether at most 15 minutes it takes for them, and that's if you're helping them through the entire process. 15 minutes for a prescription drug plan review, easy. So using technology, using these resources to help you see less people, but still provide the adequate service, still provide that experience that they come to expect with you and that gives them referrals, that's huge. Technology should enhance the experience, enhance the process. Anytime technology takes away from their consumer experience, it's not worth it. I promise you, this adds to their experience and allows them to have the, what's it called whenever you have confidence. They have the confidence when all of their friends at McDonald's coffee morning is panicking, they'll have the confidence because they're using you as their agent. Let's see. So Will, I was gonna say, I know I get really passionate about this portion of it, about is Part D plans worth it? And again, you don't have to do the calculations. You don't have to calculate when will they hit that max out of pocket. You don't have to do all that. All you have to do is make sure that one way or the other, either you're entering it in and they're entering it on themselves. This information is in Medicare Center. Medicare Center saves the drug list, stores the information, and will help you. Another cool thing that Medicare Center is doing, guys, if you've been using it in the past especially, is that if your client information is in there, and if that client information includes the prescriptions that they're taking, the plan that they're currently on, all of that stuff, Ask Integrity, which is AI for Medicare Center, come October 1st, is going to filter your list of clients and say, based on their plan changes, this tier needs to be seen first. This tier, their plan's not changing, or like it looks like they're still on the right plan for them. They don't need a meeting first thing. You can tell them that they're probably going to be okay. But this group of individuals, they have to have a plan change. It's also going to take into account their pharmacy and their medications that they're on, saying that, hey, this formulary no longer fits this client. You need to get them on a new formulary. So it's looking at both consumer data as far as how likely are they to shop this year, as well as carrier data, how much did that plan change this year? So using the technology truly will be a huge time saver for you come this AEP.
I think not only that on your shoppers and your switchers, but think about your clients that don't take any medications or maybe take a single tier 1 generic medication. You can go in within Medicare Center and create those custom tags for your clients and tag them as no meds or one generic or whatever you want to do and categorize them. And those are folks that you can either move towards the end of the year or knock out super early so that you're saving time later in the year for your more complex cases, your more in-depth clients that you have. So utilize the custom tagging feature within Medicare Center to kind of create lists, prioritize based off of those lists, and move forward in an efficient manner this year.
Judy says that Medicare Center is asking them to choose a password. Judy, it's not. And I'm going to tell you, because I thought it was as well. If it's asking them, the way that it goes through is if it's asking them right off the bat, they put in their information, because what's really cool, especially if they already have a profile in your Medicare Center account, they'll go there, they'll type in their name and their email address. If that name and email addresses matches a profile you already have made in Medicare Center, it'll automatically, that's why it's called Client Sync, it'll automatically put those two together. So they'll go through it and like, those are the drugs that I take. They're already in there. I need to update these. It's so cool. Judy, where you might be getting confused on, because I was confused on this, is that if they already have a plan enroll account, which a lot of consumers do, then, and they recognize there's a plan enroll account tied to that profile, it'll try to get them to log into that account. But if there's somebody who has never had a plan enroll account, it'll take them through the entire process, updates their information, updates their drugs, updates their providers. And at the very end, it'll say, we created a profile for you. All you have to do is add a password. You don't have to do that. You don't have to. It just says, if you don't want to have to go through this process again, give us a password. That way you can log in and just update it versus log in and put everything out there.
Correct me if I'm wrong, Olivia, as well, but with creating that password and creating that account, you'll eventually also get access to the wallet once they roll that out, correct?
The wallet's actually getting rolled out tomorrow. I'm very, very excited for that. If a consumer has a plan enroll account through you, what that does, it allows you to do two-way communication, so they can message you and vice versa through that platform. It also will have a place to store their Medicare card, Medicare supplement, Medicare Advantage, life insurance. It can store all the information in their virtual wallet, so that if they don't have their card on their person at the time of receiving a service, it's right there on their phone, making it super simple. It also will send them reminders if they have an upcoming appointment. It'll automatically send out scope of appointment, permission to contact. It'll send out everything on your behalf. So it's a really cool way for an agent to have ties with the consumer all 12 months, not just the last 3 months of the year. Now, Christina, she says, you know, Medicare Center can be tricky if you're not tech savvy. Give us a call. We're also doing a ton of, we're going to be posting a lot of videos of walkthroughs on this. Integrity has a ton in their learning center, has a ton of walkthrough videos, a ton of explanations on this. And here, before too much longer, they're actually going to release marketing through Medicare Center, to where you'll be able to e-blast your book of business, encouraging them to sign up for a plan enroll account, or encouraging them not even to sign up for an account, but just to update their own list of medications, encouraging them to set appointments, encouraging them to turn in scope of appointments. So really investing on the client management side within Medicare Center should be really cool. Okay, Michael says, gotta run. Thank you. Okay. Are there any questions, anything that I missed? Anybody still not convinced that doing, and you can, I'm not going to judge you if you're still just like, yeah, I'm not sold, I don't think I'm going to be writing PDP for my clients this year, put it in the comments. Let's have some conversation about that, because I truly believe not only would you be doing a service to your clients for that, but you're also missing the boat on incredible networking opportunities. Again, the long-term success includes prescription drug plans into your agency. It just has to. Being full service, because if you don't do it, somebody else will. And why would I go to a dentist that only does crowns when I can go to a dentist that does everything? Now, as you guys are talking, I'm going to ask, Andrew, you're welcome. Andrew, I haven't talked to you in forever. I'm sure Clayton misses you. Give him a call. Okay, I'm going to go through. Let's do this. If I didn't answer your question, or you feel like I still need some more information on this, feel free to resubmit your question, because it was chaos there for a little bit. I want to know. I want to make sure that I'm hitting on everything you guys are talking about. Oh, what was that stat about Medicare Advantage premiums and churn again? Great question. Again, 40%, it's 37%. I want to be accurate. 37% of individuals, when they were, they submitted a survey back in June, 37% of individuals said that if they saw a $5 increase on their Medicare Advantage plan, they're shopping plans. Even if they don't switch, they're gonna start shopping. Medicare Advantage people are much more loyal to a $0 premium than they are to a carrier brand. Compared to much less than that, it was, again, oh, I'd have to look at that, what it was for the Medicare supplement. The Medicare supplement was way, yes, if there was a 20, yeah, if a Medicare supplement had a $5 increase, only 14% would consider shopping. So again, Medicare supplement, people are much more loyal to that. Another interesting stat that came from that as well was talking about if somebody, loyalty based on time on Medicare. So your people who are turning 65 are much more likely to shop this AEP. People who have been on Medicare for a while, looking at your 70s to 75s, they're much less likely to shop this AEP. So if you're looking at, hey, who do I need to talk to? Who are my absolute, like I need to make sure I'm working with them? You're new to Medicare, people are much more likely to shop this year.
You're reading lots of questions on what the recommendation is from an enrollment standpoint. Do we online, direct them to Medicare.gov, direct them to call the carrier? What would your advice to brokers on the enrollment forefront be for PDPs?
Well, can you say that one more time?
Yes.
I was reading.
Getting lots of questions on the enrollment forefront with PDPs. If they're going to be non-commissionable, sometimes you don't have access on enrollment platforms to actually enroll on those. Do we recommend Medicare.gov? What do we recommend?
Oh, what a great question, because yes, so let me give you some context to this. If a plan is non-commissionable, what it used to mean was that the plan didn't want to exit because that's a horrible strategy and it's a lot of paperwork and it's a lot of movement. So they would just make a plan non-commissionable because they were really trying to discourage people from enrolling on that plan. When people don't get paid, they tend to be, that's a pretty clear sign to discourage that. That's not necessarily the case this year. A lot of the cases that the carriers just simply can't afford to pay commissions on these plans anymore. So Medicare Center and most of these Medicare Center and most e-applications, if a plan is non-commissionable, it is shoppable, but is not enrollable on that platform. That's not likely to change this year. That looks like it's going to continue to be the same case. That's at the request of the carriers. So Medicare Center does not have the capability of changing that. So if you are working with a plan that is non-commissionable, what I highly recommend that you do is fill out the paper application. Some carriers, especially this year, will continue to have those on their e-applications. So finding a way where you still maintain the ability of being agent of record and enrolling them. I do not recommend sending them directly to Medicare.gov because it does completely take you out of that equation. Something else, I saw a question earlier of saying, what if I don't certify for prescription drug plans? What if I, and that way I can just help people through Medicare.gov if I do MA but not PDP. Can't do that actually. That's actually non-compliant. When you certify with a plan, when you certify with a product, that is the carrier giving you permission to represent them on their behalf for that product. So it is actually non-compliant to help somebody navigate Medicare.gov and enroll themselves into a plan if you are not certified and ready to sell with that plan. Because again, the carrier has not given you permission to talk on their behalf. Not compliant. So if you're not certified with those plans, you can't, if you're not certified or able to sell PDP, you cannot help somebody through Medicare.gov. It is not compliant. It'll end up bad for you. What other questions? Great question, Lonnie. I've been using Medicare app forever. Can we sync that over to Medicare Center, Lonnie? So happy you asked. Medicare app is a connector platform with just different lipstick on it. So yes, this year is going to be the last time. Medicare app is going to do a one-time data dump with all their information, including pharmacies, medications, everything, and upload that into the Medicare Center account. I don't have a date of when that's happening, but I've had it confirmed several times. A Med app to Med Center data dump is coming. More to come on that.
We have a question from Sheila that I wanted to make sure we talked about. It's what if a client does not take any medications, doesn't want to renew a drug plan because of the premiums associated with it? I take no meds, knows they're going to be charged a late enrollment penalty. How do you recommend handling those clients? So wonderful question on that front. We actually created a form that is on our AEP toolkit, as well as all the beautiful information is housed there. There's actually a Part D opt-out form. What that will do, they'll fill it out, sign it, and it's your way as a broker to kind of protect yourself. Like, hey, we talked about everything that's associated with not having a Part D plan. You are still choosing to opt out of this, and that way you can retain that for your records and make sure that you're protecting yourself for this year as well.
Lee asked a really great clarifying question. Does the IRA have anything to do with IRAs, traditional IRAs or Roth IRAs? No, completely separate. Misfortunate abbreviations, but the Inflation Reduction Act has only to do with prescription drug coverage for Medicare beneficiaries. Great question. I could see why that's confusing. Sometimes I got so deep into AEP planning that I forget that there are other more popular versions of IRAs. Aaron, talking about the Med app to Med Center data dump. No, if you already have people who are on Medicare Center, it will not duplicate those accounts. It will update those accounts. So if there are medications in Medicare app that are not listed in Medicare Center, then it's basically just going to put both informations together. So you may have to go in there. It should be noted if any information was transferred over in their account, but it is possible that like, oh, I haven't taken that medication in a couple years. That medication, if you didn't update it in Medicare app, only in Medicare Center, that it will update back up to whatever they have the most of. So information shouldn't have been missing, but there may be added information in there. Great question, Lee. Well, carriers like WellCare have their own sales force to retain their value script clients. Obviously, we know most of these carriers have an internal sales distribution. It's really important when you're choosing your carrier partners to see kind of how do they accept, how do they help agent of record. For example, United Healthcare, even if they do an internal transfer, even if they say a client calls United Healthcare and says, hey, I want to move from this plan to that plan, they maintain agent of record. So not every carrier is created equal in that way. So we'd have to do some research exactly how WellCare or Aetna would handle the situations. But yeah, keep in mind, most of these carriers are going down to just one option. So let's see. Where exactly do I find that PowerPoint presentation? If you are contracted with senior marketing specialists, it's on our AEP toolkit. Under, if you scroll down, it's going to be information like CMS and educational pieces. It'll be in there, and it's a full presentation. You can look at there. Marjorie, call our office. Right now, I only have heard of one carrier who is not paying renewals, but that could change. I hate to say anything on a recorded webinar that we're going to be posted because we're doing this on, what is today, August 22nd. There is still time. There's still time for that to change. So I hate to say it on a forum that's recorded and going to be posted, but we have heard of one carrier that is not paying on renewals. Call our office.
And Olivia, Joseph asked a question on the DSNP plans. I know we said we would talk about some of the changes coming to those. So I know we're already a couple minutes long, but we did say we would talk about changes coming to the DSNP market. So I wanted to make sure we hit on that real quick.
The biggest change that we're seeing coming to the DSNP market is actually the enrollment of the DSNP market. So DSNP currently, as it stands today, if a person is let me make sure I'm clear. If a person is Medicaid eligible, they have full Medicaid status. As it stands today, they have a quarterly election to switch plans. Whatever plan they want to, doesn't have to be a DSNP plan. They can go anywhere they want on a quarterly basis, excluding during AEP. During AEP, they have to use AEP just like everybody else. This new legislation or this change is actually saying that it's treating it more, I'll say it like this, it's treating it more like a chronic special needs plan. And what it is, if an individual is on dual status, meaning they have both Medicare and Medicaid, they have an election to go into what's considered an integrated plan if they're not currently on one. Just like a SNP plan, if somebody is not on a chronic condition case, but they have a chronic condition plan and they're available, they have a one-time election to get into that one. What an integrated plan means is that that company, for example, we'll say United Healthcare, has both a Medicaid and a Medicare contract in that state. As it stands today, there are only 20 states that currently have an integrated option. I imagine more is coming because of this opportunity. You'll see a lot more, but today only 20 states have this as an option. So DSNP plans are not going away. You're going to see a huge investment into DSNP plans moving forward, especially this year. But the opportunity to enroll into a just normal DSNP plan is basically AEP or some other election like losing or gaining status, Medicaid status. They'll have to do something else. That quarterly election is going away. Now, if somebody is low income subsidy, that helps with that extra help for prescription drug plan. They do have a monthly election to change drug plans. So it doesn't affect Medicare Advantage at all. They do have an election to change drug plans, but for your D-SNP clients who want a D-SNP plan, they'll have to enroll in that during AEP. No other election exists for that. Christina, call our office. We'll get you to that Part D opt-out form. Oh, what are we thinking about this cheap WellCare PDP? Do you think they'll drastically change the formularies? WellCare hasn't told us what they're doing this year. I'm imagining they've opting in. We do know they're not paying commissions, and it's likely we'll see a $35 premium increase, but they haven't showed us their plans this year. I was considering not certify with WellCare again. If WellCare is a good plan, can I give them the phone number for WellCare? Okay, here's the thing with that. If you are advising, let me just say this, and I'm not going to point and throw rocks at anybody, but for sake of argument, if a consumer enrolls into a prescription drug plan and does not have an agent of record, you can guarantee that company is going to call them and market to them their Medicare Advantage plan. These prescription drug plans are leads to these carriers and nothing more. They're losing their butts on PDP enrollments this year. So some carriers are going to be a little more kind. I'm looking at like a United Healthcare that protects agent of record. I'm not going to throw stones at anybody, but I guarantee you, if you enroll a client, if a client gets enrolled into, let's just say WellCare, and they don't have an agent of record on staff, they are going to get called by a call center. They are going to get called by local agents because WellCare is also distributing those leads to local agents saying they're on a PDP, there is no agent of record, try to get them on an MA plan. So you're leaving your clients very susceptible to marketing if you do that. So don't do that. To enroll into the M3P, is there an application or do we know it'll be included? Julie, we hit on this earlier, but it is likely, again, carriers are still kind of finalizing that process. They'll have the ability to enroll in it at the pharmacy. They'll have the ability to enroll in it at the time of the application, and they'll have the ability to enroll in it by calling the carrier directly, likely. So there'll be multiple ways that they can enroll into the M3P. Lisa, if a drug plan is discontinued for 2025, does that open up an SEP? And Lisa, that's a really great question because it does for Medicare Advantage, but I haven't really looked at if an SAR for PDP opens up. I know it opens up an SEP for the drug side. I'm thinking Medicare or Medicare supplements GI. I wouldn't think so, but I don't know.
Med subs actually are GI if your plan leaves your service area.
Even if it's just a PDP? I know
I don't think PDPs count. I believe they do for MAs though.
Yes, I know. Well, for MAs, yes. If an Medicare, in which we do know, guys, we are expecting over 1 million beneficiaries to lose their Medicare Advantage coverage this year because so many plans are exiting, so many plans are moving, so many things like that. So 1 million people this year will have a guarantee issue right to a Medicare supplement. We know that. I don't know about the PDP side though. But yes, if a PDP is leaving an area, yes, they get an SEP to enroll into another PDP. I just don't know about the med sub side. It's a great question. Michelle, you're not wrong. I won't share your comment with everybody, but like, yes, Michelle, that is correct. Will Mutual of Omaha people be crosswalked to another plan, or will they go out without coverage if they don't change? Because Mutual of Omaha pulled out of the PDP market, it's not being crosswalked because it's a different paper. So those will need new coverage. I think I've answered all the questions. But
yeah,
guys,
I'm scrolling through. I think we did a pretty good job on getting through this.
I love it. I love your questions. Please keep asking questions. If you need more help, Kimberly, love that question. Call that number. My favorite part about what I think a lot of agents who work with us love that if they call her, you don't have to like push numbers. You call our office, you're going to talk to either Mackenzie or you're going to talk to Clarissa, and they're going to say, tell me what you need. and you're going to talk to a real person who's then going to transfer you to a real human being. You don't have to figure out this triage system of how do I answer this question to get to where I need to go. Call them, tell them what you want. They'll get you to the right person. You don't have to know. We know.
What do you mean you don't like yelling representative 5 times into the phone to get transferred to someone?
Yes. I learned one time, okay, funny story, no one asked for. Early in my career here, I had heard a rumor, and it wasn't true, but I didn't know that at the time. I was young and susceptible. I heard a rumor that if you called a certain carrier and started cussing, that they would get you to a representative faster. It would like move you to the front of the line. And so me, just little 21-year-old Olivia in the back corner office, just on the phone with this carrier, just yelling any cuss word I can think of, thinking that it would get me to a representative. It didn't. And I did have a follow-up meeting with my manager about my anger issues. So don't do that.
I had never heard that, and I'm glad they didn't try to pull that on me when I started.
Quite literally. Okay. Will you do a one-time dump for Medicare Link? Oh, Sherry. I'm so sorry, Sherry. No. Medicare Link, which is Sunfire's portal, will not do a data dump in the Medicare Center. And again, I'm not throwing stones, I'm not throwing rocks. Medicare, Sunfire does not play well with others. Sunfire does not, they don't play well with others. So we will not see a data dump from Sunfire into Medicare Center like we will with Medicare app, because Medicare app is Connecture, and Connecture is very nice and does play well with others, usually. Awesome. Last chance for questions. Speak now or forever hold your peace. We've been keeping you guys for 70 minutes, and there's still so many people that are on. There's actually more people on now than there was at the beginning, so you guys have stuck around for 70 minutes. Any final questions that you guys have? If you do, call that number, talk to Clarissa, tell her you need the help. We're here to help you guys out. This AEP is going to be wild. This AEP is going to be disruptive.
We do have one question in there, E&O coverage question. Are we covered on a non-commissionable plan? So with that, that is actually a very common misconception that E&O plans do not also cover you for non-commissionable. There are a few out there that do have specific exclusions for that, but most of the E&O policies I've seen and I've reviewed do not have a specific exclusion on protecting you on non-commissionable plans. Call your E&O provider and make sure that that is not an exclusion on yours, but most of them are going to protect you guys just fine for those.
Great question. Guys, thank you so much. I'm laughing because Sadie and I talked about this webinar before, and I said there's no need to do this multiple times. One will cover it, and it's making me think we need to do this one again. So thank you guys for being so communicative. Thank you for asking the questions. Call us, call us, call us. Let us help you. Let us love you. Appreciate you all so much. Will, thank you as always. Appreciate your knowledge. Appreciate your experience. And guys, we'll see you next time. Have a good one.